Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So whenever you encounter a USMLE style question, you need to read the last line first. This will give you an idea what to look for in the long question stem. So here we have which phase of this cardiac cycle is primarily affected in this patient's condition. So a 45-year-old patient presents to the clinic with chest pain and palpitations. An electrocardiogram reveals a prolonged PR interval. During a physical examination, the physician notes a loud opening snap followed by a rumbling, low-pitched diastolic murmur at the cardiac apex. Which of the following, which phase of the cardiac cycle is primarily affected in this patient's condition? This question is asking us about the phase, the pathophysiology, the mechanism of the cardiac cycle, and which phase is affected. This is typically a easy question, but these sort of questions do appear in your exams. So we have options like systole, diastole, isovolumetric contraction, or isovolumetric relaxation. Now, here to crack this question, you need to understand the specific ECG patterns, which represents the specific phases of the cardiac cycle. So when we talk about different phases of the cardiac cycle and the ECG interpretation, now here we can see in this image that the atrial systole is indicated by the P wave, which is called as the atrial depolarization. And the PR interval means the ventricular diastole, right? So in our patient, the PR interval is increased. It means the patient has increased ventricular diastole, or the patient also has a diastolic rumble, which means the diastolic phase of the cardiac cycle is affected in our patient. Also, going through this image, we have the ventricular systole, which is represented by the QRX complex, which means the ventricular depolarization, and also after that there is the atrial diastole. So in this picture you need to understand the main basic thing, that the PR interval gives you the ECG interpretation on the ventricular diastole. Now, do you can also see in our options that we have isovolumetric relaxations or isovolumetric contractions. Okay, now that is represented by the pressure volume loop. Now, these pressure volume loops are generally plotted for the left ventricle. Yes, you can also plot this for the right ventricle, but that is not clinically significant. Generally, whenever you see the pressure volume loop in the USMLE questions or in your textbook, then this is all talking about the left ventricle. Now here we can see that from A to C, okay, from point A to C, it all represents that for example, let's say at point A, the mitral valve opens, then the blood starts filling into the ventricle. Now, this is the ventricular filling phase from point A to C. A to B is the early filling, and B to C is the late filling phase. Okay. Now, the left ventricular volume goes on increasing. Okay, there is also somewhat increase in the pressure, but not much. But there is increase in the left ventricular volume. Now, when the mitral valve closes, then the left ventricle starts contracting. Now, from the point C to D, it mentions the isovolumetric contraction phase. Okay, now it means that the volume in the ventricle is not changing because the valves are closed. Both valves are closed. So here the left ventricle acts as a closed chamber. The volume is not changing, but the pressure starts increasing because of the contraction. When the left ventricular pressure becomes more than the aortic pressure, then the aortic valve opens, and then occurs the, and then there is the systolic ejection phase. Okay, from point D to F represents the systolic ejection phase. And when the blood starts leaking from the left ventricle towards the aorta, at some point of time, the left ventricular pressure becomes less than the aortic pressure, and then the aortic valve closes. So the point F represents the aortic valve closure point. Now, before the closure of before the opening of the mitral valve and um, the start of the real diastolic phase, there is the ventricular relaxation phase. Okay, now in this phase the pressure is decreasing, but there is no such change in the left ventricular volume, and now this phase is called as the isovolumetric relaxation phase. Okay, now here also in this phase the left ventricle is acting as a closed chamber because both valves are closed, and again at some moment of time ventral valve will open, and again the ventricular filling phase will occur. Now, the correct answer to that question is diastole. You all know by now. So the diastole encompasses the relaxation phase of the cardiac cycle when the heart chambers fill with blood. The presence of a prolonged PR interval and a diastolic murmur suggests that the primary issue lies in the diastolic phase, specifically during the ventricular filling phase. Here I also have a next question with you guys. Again, we will read the last line first. So, which of the following changes in hemodynamics is most likely to occur in this patient? So, this question is asking us about the change in the hemodynamics. So, a 60-year-old male presents to the emergency department with severe chest pain and shortness of breath. His past medical history includes hypertension and hyperlipidemia, for which he takes daily medications. On physical examination, his blood pressure is 180 upon 100 millimeter of mercury, heart rate is 110 beats per minute, and respiratory rate is 20 breaths per minute. And electrocardiogram reveals ST segment elevation in leads 2, 3, and AVF, suggestive of an inferior wall myocardial infarction. Which of the following changes in hemodynamics is the most likely to occur in this patient? Decreased cardiac output, decreased systemic vascular resistance, increased preload, decreased afterload, and decreased mean arterial pressure. Here we can see that we have this poor old 60-year-old man, and he has symptoms of MI basically, and he also has hyperlipidemia and hypertension, which are the basic risk factors of MI. His blood pressure is also increased, his heart rate is increased, and again he also has lead to 3 AVF, which is suggestive of the inferior wall myocardial infarction. Now, let's go through some of the basic concepts. So what is preload? So preload is approximated by the ventricular in diastolic volume. Now, this preload is mean that before the heart starts contracting, before the left ventricle enters into the contraction phase, what is the volume of the blood that is present in the left ventricle? That is the in diastolic volume. Or we can say the amount of blood that is present in the left ventricle just before it starts contracting, just before it goes into systole. It depends upon the venous tone and the circulating blood volume also. And what is afterload? So afterload is the blood volume of the blood remained in the left ventricle after a full systolic phase. Okay, and that is called as afterload. Now, mean arterial pressure equals to a cardiac output into the total peripheral resistance. This is the simple physics we all know. And then there is the cardiac output. Now, cardiac output is equal to the stroke volume into the heart rate. Now, initially, the cardiac output is maintained in case of MI because the heart rate is increased, right? But ultimately, this heart rate will also settle down, and the cardiac output will ultimately decrease. Now, in this patient, which is presenting with an inferior wall MI, is associated with damage to the right coronary artery. The right coronary artery supplies the blood to the right atrium and the ventricle. Now, during an inferior wall MI, the right ventricle's contractility may be compromised, and which leads to the impaired systolic function. So when the right ventricular contractility is compromised, then there will be impaired systolic function. So the correct answer is increased preload. The right ventricle's preload is determined by venous return, and in the context of an inferior wall MI, it is likely to increase due to the impaired right ventricular function. Now, this can lead to the jugular venous distension and hepatic congestion. Okay, a decreased cardiac output, given the compromised right ventricular function, um, the cardiac output may indeed decrease, but this is not the primary change associated with this condition. Now, the decreased systemic vascular resistance, this is less likely to occur acutely in response to an inferior wall MI, and the body typically responds to MI by increasing the systemic vascular resistance to maintain the perfusion pressure. Decrease afterload. So afterload refers to the resistance of the left ventricle must overcome to eject the blood into the systemic circulation. This is the alternate definition, and this value may remain relatively unchanged in the setting of an inferior wall MI. Also, decreased mean arterial pressure. So given the patient's elevated blood pressure on presentation, a significant decrease in the mean arterial pressure is not expected initially. Okay, we have another question with us, so which says that which of the following valves is most likely affected in this patient and what structural changes are commonly associated with this condition? So a 55-year-old patient with a history of rheumatic fever presents with progressively worsening softness of breath, fatigue, and peripheral edema. So on examination, a heart's mid-diastolic murmur is heard at the left sternal border. Now, which of the following valves is most likely affected in this patient? And what structural changes are commonly associated with this condition? Here we can see the patient has generally respiratory system, the lung symptoms, right? Now, here we can see the options, that is the aortic valve, leaflet thickening, mitral valve, annular dilation, pulmonary valve, commissural fusion, and a tricuspid valve coordinated rupture. Now, here you can see that the patient has lung symptoms. The lung symptoms are generally due to the left-sided conditions or the left-sided valve disorders. So the left-sided valve disorders are the mitral valve, right? So whenever there is a dysfunction of the left valvular side, then there is lung symptoms. So you should remember L for L, lung for left, and right-sided everything else. So we can here see about the auscultation points, right? So the aortic auscultation point is in the right second intercostal space. Pulmonary auscultation point is in the left second intercostal space, and then there is the tricuspid, which is in the uh, just lateral to the sternal border, and then there is the mitral auscultation point, which is just there in the apex area. Okay, but here our patient has left-sided symptoms, and the left-sided valve is the mitral valve, right? Now, so the mitral valve, the mitral valve murmur can also be heard on the left sternal border. So we know by the symptoms and by the valve associated, then we can say that this is the left-sided murmur, or this is the murmur of the mitral valve, right? So here you can also see in this picture that whenever there is the mitral valve dysfunction, the blood flow is back into the left atrium, and then there's a left atrium dilatation, the increase in the left atrium pressure, and this pressure will be transmitted from the left atrium towards the lung through the pulmonary veins, and ultimately there will be pulmonary congestion, and there will be pulmonary symptoms happening in the patient. So the correct answer is B, that the patient in this scenario with a mid-diastolic murmur, which is characteristic of mitral stenosis, right? So mitral stenosis commonly results from the sequelae of rheumatic fever, during which the mitral valve leaflets can become inflamed, leading to scarring, fibrosis, and thickening. And this thickening narrows the valve's opening and impairing the blood flow from the left atrium to the left ventricle. Now, again, if the blood cannot pass from the left atrium towards the left ventricle, there is increase in the left atrium pressure. If the blood passes from the left ventricle towards the left atrium abnormally, it will increase the left atrium pressure. Ultimately, the both pathologies will lead to increase in the left atrium pressure. Now, in response to this, the left atrium will dilate over time to accommodate the increased volume, which leads to the symptoms of shortness of breath, fatigue, and peripheral edema. So I think now that everything I told is actually making sense. So option number A suggests aortic wall pathology with leaflet thickening. However, the key clue in the question was mid-diastolic murmur, which is not characteristic of aortic valve disorders. Aortic stenosis typically presents with a systolic murmur. Commissural fusion of the pulmonary valve leaflets is associated with congenital heart defects rather than the rheumatic fever. And also the pulmonary valve pathology typically results in the issues of the right side of the heart. Okay, you will generally have hepatomegaly or jugular venous distension like things. Coordinated rupture produces a systolic murmurs, and which are generally right-sided. So I hope you enjoyed this lecture. We will again be back with another super duper concept. Till then, keep studying, keep studying hard. Thank you very much. We will again meet next time with the next video.